Good afternoon, everybody. I think we're ready to get started. You can all continue to enjoy your lunch while we talk. My name is Howard Gleckman. I'm the editor of TaxVox, which is a tax and fiscal policy blog of the Tax Policy Center. You can find us at taxvox.org. And welcome to this program sponsored by the Committee for Responsible Federal Budget, entitled Busting the Budget, Healthcare Costs or Entitlement Programs. When Maya McGinnis asked me if I wanted to moderate this panel, I told her that I couldn't wait. I think there's no issue more important than health care as we struggle with the nation's fiscal future. As much as it pains me to say so, I think health is even more important than tax policy. Not only do we have a key issue on the table here today, but we also have a panel which is both distinguished and passionate on this subject. I expect we'll have an informative and a provocative discussion this afternoon. Let me just take a couple of minutes to set the stage. As CBO reported just a week ago, the new president is likely to take office with a budget deficit in the neighborhood of $500 billion and a national debt approaching $6 trillion. Assuming the Bush tax cuts expire and discretionary spending falls as a share of gross domestic product, in other words, assuming the current law baseline, the national debt will approach $8 trillion by the time the next president leaves office, assuming he serves for 8 years. And of course, we have two presidential candidates who are happily promising trillions of dollars more in tax cuts and new spending. Most troubling, though, is, I think everyone on this panel will agree, both annual deficits and the debt are scheduled to rise to unimaginable and unsustainable heights in the coming decades. Spending, which has hovered in the neighborhood of 18% of GDP since the end of World War II, is likely to exceed 30% by mid-century. Except for the peak years of World War II, this is unprecedented in U.S. history. As I think the panelists will also agree, the prime driver will be the rise in Medicare and Medicaid costs. Finally, I think they'll agree that we do need to address this, and the sooner the better. Something very big has to change, but what? And that takes us to today's subject. If I may be permitted to oversimplify just a bit, the question on the table is this. Is the Medicare problem a Medicare problem, or is the Medicare problem a healthcare cost problem? The answer to that question will profoundly affect the direction you take as you confront the nation's fiscal dilemma. So today we'll hear a broad perspective of answers to that question, and our speakers, and you all know them all, so I'll just introduce them very quickly, are Henry Aaron, Senior Fellow at the Brookings Institution, Julie Barnes, Deputy Director of the Health Policy Program at the New America Foundation, Bob Greenstein, Executive Director at the Center for Budget and Policy Priorities, Maya McGinnis, who's our host, who's the President of the Committee for Responsible Federal Budget and the Director of the Fiscal Policy Program at the New America Foundation, Alice Rivlin, who's Senior Fellow at Brookings, and Gene Sterling, who is newly the Vice President at the Peter G. Peterson Foundation. The format is going to be pretty simple. Each of our panelists will talk for about 5 minutes. We'll go right down the table. We'll have some discussion among ourselves, and then we'll open up to questions from all of you. And when time comes for questions, we'd like you to please introduce yourself and also keep your question to a question. So why don't we start with Henry Aaron?
Thank you, Howard. You should all have a handout, one page. If you don't, raise your hand. There are a few more copies in the back, but I'm going to refer to the numbers on this page. We all agree that the nation faces very large projected budget deficits in the long term. And that raises two questions. First, what causes them? Second, what should be done about them? The answers to those two questions need not be the same. But I believe one should know the source of the problem before one prescribes a solution to it. I hope you have this handout because it indicates how much each major category of government spending and taxes is projected to change between 2007 and 2050. I choose the beginning point and the end point Later on, Bob Greenstein is going to talk about the present value of the changes in spending in these categories, but that is a different perspective. The numbers on this table, in my view, tell a very simple story. Total spending is projected to increase more than 9% of GDP, and that is excluding interest payments. We're looking at the primary budget here. Revenues are projected to increase a little bit less than 1% of GDP, for a swing toward deficit in the primary budget of 8.6% of GDP. What causes that swing? The answer is striking. More than all of the swing is attributable to projected increases in Medicare and Medicaid. The two health programs are projected to claim an additional 11.1% more of GDP than they do today. The rest of the budget, excluding interest, but including Social Security, all other mandatory spending, national defense, and domestic discretionary spending, is projected to shrink by a little under 2 percentage points of GDP. The rest of the budget, on balance, is not projected to swing toward deficit. Healthcare spending is a gargantuan challenge. The projected deficits, we all agree, I believe, are intolerable and cannot be allowed to occur. But pinpointing the source is not the same as showing what should be done about them. What are the possible fixes? Let's start with spending. We all know that Social Security faces a projected long-term deficit. Closing it isn't really urgent. The system is in surplus today, but it is very important. If we followed the template of the 1983 Greenspan Commission, we might cut spending and raise taxes roughly equally. And closing that gap in Social Security would certainly help with the overall projected deficit. But the fact is, it wouldn't take us very far toward offsetting the total projected spending increase. The rest of non-health domestic spending and national defense spending surely contains some good targets for cutting, but defense and domestic discretionary spending have been shrinking as a share of GDP for decades. They are assumed already to continue shrinking over the next 4 decades. Further cuts as a share of GDP are going to be hard to find, and they will, let's face it, always be hostage to foreign military emergencies. Which brings us to healthcare spending. The simple fact is that in the absence of national health system reform, major cuts in Medicare and Medicaid are impossible without reneging on our nation's promise to assure roughly the same standard of health care that the rest of us enjoy to the elderly, the disabled, and the poor. I believe that a sizable slowdown in the growth of overall health care spending is possible, but only in the context of overall health system reform, and even then we will not, nor should we, prevent a sizable increase in the share of GDP we spend publicly on health care for vulnerable populations. So, I have 5 conclusions. 1, projected deficits are large and unacceptable. 2, forestalling them through cuts in spend on everything but health care spending can help, but not enough. 3, health care spending will and should go up along with taxes to pay for it. 4, slowing health care spending is possible, but only within the context of a reformed health care system. 5th, and finally, we face a health care problem, not an entitlement crisis, and framing the budget problem as an entitlement crisis obstructs productive debate. Thank you.
Great, thank you, and I'd like to add my welcome to everybody. Thanks for coming today and joining us. So I think the issue that we face is one, clearly both of policy and politics. And I think to start off, there are many points, the biggest two of which we will all agree with. One, the fiscal imbalances that the country faces are too large to be ignored, and we have to get started on addressing those problems as soon as possible. And two, the largest contributor to those problems is certainly excess growth of healthcare costs. There are different estimates that are out there for what's contributing how much over time, and I would just point out a couple points which I think are important. One, you need to look at the overall growth of government, the imbalances, not just in the major health care programs, Medicare and Medicaid, but also look at Social Security and the rest of the budget. Two, I think we need to think about the different time period. So it's very important to look at the whole long term. We look at the structural imbalances that are in any system, particularly intergenerational systems like Medicare and Social Security. You need to look at the 75-year time period. You also need to look at the next 10 years, 20 years, 30 years, because the one thing we know about this problem is that it is unsustainable. Changes will have to be made. Projecting this growth of healthcare costs, figuring out how much it's going to grow beyond GDP over long periods of time, we know that will change. We just don't know when it will change. But the bottom line that I think everybody's going to agree with is that the fiscal gap is problematic. It weakens the economy. It leaves our budget without the flexibility that we need. If there's ever been a day that exemplifies the need for fiscal flexibility, unfortunately that day would be today. You know, when you talk about financial market problems, Fannie and Freddie, when you talk about things we've seen in the past, whether it's the war in Iraq or Katrina, you need to have a budget that has enough flexibility that can respond to important needs as they come along. Promising all these programs, particularly ones that grow beyond the economy, takes away that flexibility. And I think the problem really breaks down into two. Oh, and there's a final problem, of course, with the fiscal imbalances, which is that there's an intergenerational imbalance that results from it. When we spend so much today, we don't save the flexibility or the strength in the economy to pass to the next generation to meet the new needs and opportunities that will happen in the future. So I think that this breaks down really into two camps. Do we need to deal with the entire healthcare system, which is what Henry was talking about, or do we need to deal with the budget and focus on entitlements? Here's the problem that I see in talking about focusing on this entirely as a healthcare system problem. We don't know enough about how to slow the curve of healthcare. There's a lot of progress that's going on. I certainly think the Congressional Budget Office is really paving the way here by putting out studies, by putting out options, by kind of creating a competitive environment where more people are moving into healthcare analysis. But we still don't have the answers. At the same time, we know that we need to get started on this as quickly as possible. We need to get started on this years ago or decades ago when we knew that these long-term imbalances existed. So saying we know what the major problem is, but most of our solutions at this point would actually cost money. We hear people talking about the importance of expanding the pool of health insurance to bring everybody into that. That might be part of the solution, but that will cost money. We hear people talking about the importance of bringing in a health IT system. That will probably be part of the solution, but that will cost money. When we do talk about the few kinds of things that people are pretty certain would make a major contribution to saving money, for instance, something like the exclusion from employer-provided health care, even though analysts on both sides of this issue tend to agree that that would be a very important step in the right direction, we don't have the political will to move on those things yet. So we're not gaining the traction, and we don't have the knowledge on the healthcare saving costs that will be necessary to get started. So while we're at the preliminary stages of the healthcare debate, we're well beyond that in terms of the time to address the fiscal challenges. So given where we are, I think it's far more sensible to say that what we're what we're talking about is one of those scenarios where everything is going to have to be on the table. We need to talk about how we're going to slow the growth of the various different parts of the budget, from defense to discretionary to other entitlement programs like Social Security, and certainly healthcare is going to be involved in all of that and going to be the major piece of it. But I think it's more likely that you see a budget deal that addresses the short-term deficit problem, hopefully a fix for Social Security, and then kind of round one of healthcare. Let's put all the improvements that we can to healthcare out there and try to have some kind of healthcare package, knowing full well it will not be close to enough to close the healthcare gap that we face. But it's sort of the beginning, and we know we'll have to revisit that issue 10 years down the road. If I'm also looking at the budget and thinking about where we should head, I would say it's beyond a problem of fiscal imbalances. We also have so many unmet needs in the investment area that we also have to be thinking about making the budget more flexible to deal with unmet needs in infrastructure, in education, other kinds of spending that actually have long-term economic returns. And finally, I would end with the point that I think in all likelihood we will spend more on health care as a share of the economy going forward than we have in the past. That's what happens when an economy gets richer, and that's what happens when a society ages. And we know that aging is a big piece of all of this. That means even if health care is the entire problem, it's not going to be the entire solution. I kind of liken it to that, some of the numbers Henry was just talking about. If you look at the long-term budget problem, the entire problem is spending. It's not taxes and spending. Taxes are projected to be above historical levels. Spending is the problem. The solution is going to be something of both. We're going to talk about raising taxes and cutting spending. I think the same applies for health care. The problem is primarily driven by health care, but the solution is going to have to include all parts of the budget. And that's the discussion I think we need to get started on as soon as possible. Thanks.
Thank you. I'm so much shorter than Maya, apparently. I'm honored to be here with this distinguished panel today. I'm so glad my colleague at New America, Maya McGinnis, invited me to represent New America's health policy program. My name is Julie Barnes, and I am here on behalf of Len Nichols, the director of our healthcare policy program. You know, we share Maya's concern about our nation's budgetary crisis and only support an economically sustainable healthcare system. But we at the policy program at New America believe, the health policy program at New America believe that it's just undeniable that the healthcare costs are the main reason why our entitlement programs are in crisis. So it seems like the real question for today is, other than the philosophical question about whether or not we should be offering these benefits to our most vulnerable, the real question is, are we capable of reducing health care costs to have a fiscally responsible entitlement program? And we disagree with Maya that we don't know how. But the second follow-up question is, even if we're capable of bringing those health care costs down, is it politically viable? And again, we disagree with Maya that it's not. So our director, Len Nichols, couldn't be here today, so instead of our resident healthcare economist, you have our resident recovering healthcare attorney. And in fact, I'm a recovering healthcare litigator. And we litigators have a saying that I thought was kind of appropriate for today. When we prepare to go to court, we have a tendency to say, you know, if the law is against you, hammer home the facts. And if you've got bad facts, you hammer home the law. But if you don't have the law and you don't have the facts, you just hammer the other side's economic expert. And, you know, lucky for me, the facts are on our side. So I don't need to hammer home any economists today, although I have to say I'd be glad to have Henry Aaron as my expert witness anytime. But I actually feel fairly lucky today because as complex an issue as this is, it's really not that difficult to make the case that reducing health care costs is the main and most important fiscal policy goal that we have right now. You know, Peter Orszag, our CBO director, said that in his most recent report, and I quote, "The federal budget is on an unsustainable path primarily because of rising health care costs," just as Henry Aaron just said. Well, then let's deal with our primary problem, right? How to bring health care costs down, not change the nature of the entitlement programs. That would be like throwing out the baby with the bathwater. And you know, that's kind of an apt metaphor because there are babies in this bathwater. You know, there's some grandmas and grandpas in this bathwater. So we need to be really careful about determining how we can afford to protect health care and Social Security needs for our nation's most vulnerable. And it turns out we can afford it. We can afford it by bending the health care cost curve. And we know how. So I said the facts are on our side. Let's talk about facts real quick. We know that roughly 1/3 of current health care spending adds little or no clinical value to Americans' lives. That means that we spend money on things that do not make people healthier. Duplicative tests, preventable hospitalizations. Our system could save money and improve care by reducing unnecessary spending. And we're talking about a lot of money. So here's what else we know. If we were able to reduce unnecessary care by just 10% each year, for the next 10 years, 10% each year, for the next 10 years, we would have $900 billion we could use to reform Medicare and Medicaid, say, or cover the uninsured, or I'm sure there's other things that we need to be doing in the budget. And here's another thing. The question that we really have about bending the health care cost curve is, can we do it? Maya just said that she doesn't think we can have a great enough effect on bringing those health care costs down. But the great thing about my quitting the law firm, my quitting the law firm and coming to work for healthcare policy is that I happen to know that we can. That's what we do every day. We find out about these great innovations in both public and private sectors that are doing these incredible things to dramatically reduce healthcare costs and improve quality at the same time. So one of those ways that we're doing this is payment reform. Medicare has got to get out of the fee-for-service business. What we're doing is paying for services based on volume. How many people can you get in? Not on the quality of care. MedPAC just recommended doing away for fee-for-service. It's not a new idea. Medicare pilot programs and private experiments on bundling health care payments are all over the country. There's another idea called medical or health care homes, which basically allows primary care clinicians to share in savings by better coordinating care, by spending more time with patients, by preventing diseases from happening before they get too expensive. These are ideas that really can bring health care costs down. Another idea, again, backed by Peter Orzag, our CBO director, comparative effectiveness information is something we need to disseminate. It's something that we can do across the country to bring scientific knowledge into the health care cost scenario. Now, I'm just going to defend one before I sit down. We disagree with Maya that we don't have the political will to get this thing done. And we have 3 examples. Both presidential candidates believe that health care costs are the #1 problem, and they pose comprehensive solutions. 2, both houses of Congress have introduced bipartisan, comprehensive health care reform bills, and they have much more than just token support. And I noticed Charlie Stenholm was in the audience, that we've got a House working group full of blue dogs and moderate Republicans who support fiscally responsible health care reform. So this is progress, and this is real bipartisan support for real health care reform. And the third thing is we finally have the major stakeholders agreeing. Insurers, physician groups, consumer advocates, unions, employers, even NFIB. We have AARP back there, I noticed. They're part of this. We are all agreeing before the election is over that major health care reform must happen. This is progress. So we at the New America Health Policy Program believe that we are in an excellent position to change the trajectory of the health care cost curve. Thank you very much.
I love a good debate, but I think it's important to debate the right question. And the problem with the question that we're debating today is the "or" in the middle. Do the solutions to projected deficits in the federal budget lie in reforming the 3 major entitlements, or in comprehensive health reform, or, I might add, and not just to please Howard, or in reforming taxes? And my answer is an unequivocal all 3. I don't think we get to choose. We have to do all 3 and get them soon. We need a budget process that will make the choices clearer. It won't make them easier, but it could make them clearer. We also need widespread public understanding of the consequences of inaction and the political will to get the decisions made. I don't think this intelligent group of people, both on the panel and in the room, is helping the cause by arguing about false choices. We don't have these choices, and we'd better move on to figuring out what to do. Now, we're not arguing about the projections. Everyone realizes that the budget is on an unsustainable track. Spending will rise faster than revenues over the next several decades, and the current track would generate deficits that simply could not be financed. But the budget problem on the spending side arises out of two sets of facts about the wider society's future, which dominate projections of the future of all spending, public and private. There are demographic facts. The population is both aging and living longer. It is aging especially rapidly in the next 2 or 3 decades because of the baby boom bulge. So we will have fewer working age people per older person in the foreseeable future, particularly that will rise rapidly as the baby boom bulge passes through the retirement years. And second, there are the healthcare facts. Medical care is getting steadily more effective, more expensive, and more people want it. And moreover, we don't deliver medical care efficiently, so we have a rapidly rising rate of growth of spending from an unnecessarily high base. These two sets of facts show up in the projections of spending patterns for our whole economy and in the federal budget. In other words, they affect all budgets, public and private. More spending will be devoted to older people relative to younger people in the society as a whole, and more spending will be devoted to medical care versus other things. These two sets of facts show up in the federal budget, mainly in 3 major entitlements, or as I prefer to call them, mandatory programs: Social Security, Medicare, and Medicaid. Projected Social Security spending rises quite rapidly over the next couple of decades as a percent of GDP, and then it levels off, and Medicare and Medicaid rise steadily for the foreseeable future. In the long run, Medicare and Medicaid dominate because they're rising faster, but between now and about 2030, a big piece of this increase in spending is Social Security. If you look at 2080, it tends to be even more dominated by the medical care story. If we could project spending for the whole economy on a similar basis, present trends continue, we'd see exactly the same thing. Spending by the elderly and for the elderly, public and private, rises fast in the near term, slower after that, but health care spending keeps on rising as a percent of GDP. Now, what should we do? 4 general objectives seem to me obvious. One is encourage people to work longer. Now, that will require multiple approaches, but one of them is to change the incentives in both public and private pension programs. From a federal point of view, this means changing the age of retirement, raising the age of retirement in Social Security, and indexing it to longevity. It may mean other types of pension reform. Just because Social Security doesn't dominate the federal spending growth picture in the very long run doesn't mean it shouldn't be part of the solution. Second, deliver medical care more efficiently. We've got to, as everybody has said, discourage wasteful and low priority uses of health care, and we know they are large, especially discourage expensive, wasteful use of expensive health care. This is a whole system problem, but Medicare is a very important payer, the most important payer, and it can lead by restructuring its reimbursement system to reward efficient and effective practice. We should also move toward universal coverage with spending controls as fast as possible. There are competing models to do this. I suspect we will do it incrementally, either building on the employer-based system and filling in the cracks, or reforming the individual insurance market and using vouchers or refundable tax credits. But we need to recognize 2 things. In any system, one of the important ingredients will be collecting evidence of effectiveness and creating payment incentives to use it. We should begin doing that in Medicare and set up ways of bringing the private sector into the game. And as others have noted, however we reform the health system, we're going to be under continuous upward pressure from health care spending. Third, we should shift the expenses of an aging society onto the private sector where possible without injuring the most vulnerable. And fourth, we should reform taxes to make them more equitable and efficient. Even if we do the first three, the share of government in the economy is likely to rise, mostly because of health care, and we need drastic tax reform to reinforce the pension and health care reform and minimize the damage of a rising tax burden on productivity and growth. This set of objectives requires an agenda for entitlement reform, which includes both Social Security and Medicare, plus an agenda for wider health reform and tax reform. I want to make one final point about political consistency. Those who reject efforts to reform the three big entitlement programs often allege that such reforms are politically impossible. They say they favor changing Medicare reimbursement to reward effectiveness, and they favor raising the retirement age in Social Security, but they believe the political opposition is overwhelming. It will never happen. For reasons that escape me, they think the political obstacles to comprehensive health reform will be less daunting. I guess I just haven't been around Washington long enough to understand this argument.
Thank you. I was going to start by commenting on how I thought the central question was a false distinction, but that's what Alice just did. And I also would start by endorsing her all three conclusion. We need to address healthcare cost growth system-wide, make some changes in Social Security and Medicare, and raise more revenue. I'd like to make four key points. The first is there really is no general entitlement crisis. I think the numbers are open and shut case on that. Now, let me be very clear. Of course, there's a big issue with Medicare and Medicaid, and to a lesser degree, Social Security, as a result of rising healthcare costs and the aging of the population. But if you look at all other entitlements in the federal budget, other than those three programs, take all other entitlements as a group, what you find is that they have for 30 years been declining as a share of the gross domestic product and as a share of revenues, and that they are projected to continue to decline as far as the eye can see out to 2050 or beyond. The fact that they are structured as entitlements does not cause them to explode, obviously, if they are declining as a share of GDP. Now, that doesn't mean there aren't any opportunities in any of them, like farm price supports, to get some savings, but I think we should define the problem clearly. Secondly, when we talk about health care entitlements, everybody on the panel is saying single biggest driver in the nation's long-term fiscal problems, Henry started with this, projected rate of growth in health care entitlements. We need to be sure to include in that definition the health care and, to a lesser degree, retirement entitlements that are in the tax code. Back in the mid-90s, when we had the last entitlement commission, the Kerry Danforth Commission, that I had the privilege of serving on, Alan Greenspan testified before us and specifically said these are tax entitlements. And in particular, the health care tax entitlements rise rapidly in cost, just like Medicare and Medicaid do, and for the same reason. We also should be sure, as Alice just indicated, to make sure that revenues are part of any discussion about the long-term fiscal problem. We recall that 7.5 years ago, at the start of 2001, CBO was projecting surpluses as far as the eye could see. Alan Greenspan was worried about overly large surpluses. We've just completed an analysis of what happened, what's responsible for the huge change since then. And the single largest factor, the data are pretty clear on, are not changes in economic and technical factors, although those are quite significant. The single largest factor is the cost of the 01 and 03 tax cuts. If you make them permanent, that is about 1.9% of GDP in cost, including the costs of the increased costs of AMT relief that result from those tax cuts. The actuaries tell us that the Social Security shortfall over 75 years is about 0.6 or 0.7% of GDP. CBO projects the Social Security shortfall at 0.4% of GDP. The cost of making the tax cuts permanent is about triple the size of the Social Security shortfall. Now, both Social Security and revenues, of course, as we're all saying, are dwarfed by the health care issue, particularly in the area of Medicare. And I do want to be clear that I probably, most or everyone on the panel, I don't know, would very much favor adopting the MedPAC recommendations, for example. But if you adopt all the MedPAC recommendations and the President's recommendation to raise premiums for higher income beneficiaries on top, you've only closed a very modest portion of what you have to do to deal with the long-term fiscal crisis. You can't get Medicare costs and Medicaid costs down to a path that makes the overall budget work unless we can slow the rate of growth of healthcare costs system-wide. Since 1970, the rate of growth in Medicare costs per beneficiary has mirrored. It's actually a tiny bit below the rate of growth of costs of, per beneficiary system-wide, which I think is why last week Peter Orszag said, quote, "Bending the cost curve on healthcare is the central long-term fiscal challenge facing the United States, period." Now, I do think Alice made a critical point that one of the levers to slow the rate of growth of healthcare costs system-wide are certain reforms in Medicare that one hopes then feed into system-wide changes in healthcare delivery. My last point quickly is I think we make a mistake if we go into these discussions thinking that we have an extraordinarily rich set of programs for a wealthy elderly population and that they are a fat target. In fact, 2004 data, about 86% of Medicare beneficiaries were under $50,000 a year, 57% were below $25,000 a year. The Social Security replacement rate, the rate of prior wages that the benefit replaces, is well below the average for OECD countries. It's now about 39% for the medium earner, and it's projected to already drop to 32% by 2030, both because of the gradual increase in the Social Security retirement age enacted in '83, but also something that doesn't get enough notice, because Medicare premiums are collected by being subtracted from the Social Security benefit. The benefit rises with CPI, but the premiums rise with health care costs. So there's already an erosion for two reasons in Social Security benefits that are slated in coming decades. Politically, I think that means there are, not that we can't or shouldn't do things, just there are limits in how much money one is going to get out of benefits for the elderly. And it takes you back to this isn't an either or, it's both and. Yes, some changes are needed in Social Security and Medicare, and we need more revenues. But unless we find ways to also significantly slow the rate of growth in healthcare costs, there's no way we can get there from here.
You know, when this session was first set up, people thought we were going to engage in an intensive debate. I'm not so sure we've met that standard. By way of comparison, I'm reminded of a few debates historically. For instance, a member of parliament once said to Disraeli, "Sir, you will either die on the gallows or of some unspeakable disease." "That depends, sir," said Disraeli, "whether I embrace your policies or your mistress." Or the great debate between William Faulkner and Ernest Hemingway, Faulkner about Hemingway, "He has never been known to use a word that might send a reader to the dictionary." To which Hemingway responded, "Poor Faulkner, does he really think big emotions come from big words?" Or George Bernard Shaw versus Winston Churchill, Shaw to Churchill, "I'm enclosing 2 tickets to the first night of my new play. Bring a friend, if you have one." To which Churchill responded, "Cannot possibly attend first night. will attend second, if there is one. I'm hoping Howard can engage us in a bit more debate maybe than we've had now, but let me add my own take on the discussion so far. I think the central issue to me, and I think in large part a big issue to the Peterson Foundation, which I've joined, is that never before in our history, in the history of this nation, has so much been committed to so many people for so far into the future. And that prior commitment takes away from people the fundamental right to vote over time for what they think are the most important needs of their time. It takes away from the youth in particular voting rights over whether they want larger taxes or smaller taxes or bigger government or smaller government. And it sets up this debate with current policymakers over how much they want to sustain of what now dead or retired policymakers put into the law many years ago. That to me is the fundamental debate. And so then the question is, how much do we want to preordain into the budget? And now we can get into this debate, which we'll get into in a more narrow sense. Well, how much of that preordaining in the budget is in health care versus retirement versus other things, versus the tax code, by the way, which has a lot, which is not in the numbers, is a lot of the numbers that we do for comparisons, partly because we don't do 75-year numbers, so we can't quite tease them out the same way. Now, in that narrow debate of whether we're talking about health or retirement or demographics, there's a lot of interaction terms, too, that confuse the issue. One of them, well, is that, the increase in the number of elderly increase health costs, right? If we have more elderly, even if health costs weren't rising because of prices or quantities used, that would just increase health costs per se. There's also an interaction term, making sure which way it would drive your numbers. In the definition of the elderly, I've always really been bothered by the failure to distinguish between an increase in the number of the elderly because a larger percentage of our population are in the last years of life, say the last 10% of their life. That largely is caused by declines in the birth rate, versus the fact that we're living longer. The fact that we're living longer doesn't mean we have more elderly. It means just we haven't adjusted our definition according to how long we have. Another big issue for me is, well, what period do we count if we want to engage in this debate? Well, why do we want to start with 2008 or 2009? Why don't we start with 2050 or 2000, I'm sorry, why don't we start with 1950 or 1980? Because in point of fact, we've now moved to a world, for instance, where we spend in excess of $20,000 per elderly person and less than $5,000 per child. That's in the federal budget. Now, we can debate whether that's the right mixture or not, but I don't know why that should be taken for granted, and then we decide we just want to build off of that in terms of growth rate. So given that we have this debate over what period do we count, what are the interaction terms, and by the way, in these numbers, very few people have included the revenue effect. Just the decline in number of workers, an issue to which Alice, I thought, spoke eloquently. The decline in number of workers means, over the long term, a decline in GDP that's non-trivial, that's substantial, and also a decline in the revenues brought about by those additional workers. Now, is that a health issue? Is that a demographic issue? Or is that an issue we have to address more broadly? So I think where this panel's going, and I think most of us are on the same wavelength, is, okay, then what do we want to think about for the fixes? And in the fixes, I think we have to deal with such issues as, do we really want a system that encourages middle-age retirement, whether it's middle-age retirement that includes health benefits or not health benefits? Is that really the system we want? Not just because of what happens to the budget or what might happen to deficits, it's because we're abandoning the the really old people, in favor of more and more of a middle-aged group of people. How about health care? Do we really want a system that continues to favor acute care over preventive care? Or do we want a system that gives us $500,000 a year surgeons and only $100,000 a year pediatricians, by the way, which is another interaction effect if you think we're going to have more and more elderly getting the surgeons relative to the number of children getting the pediatric health. So I think it's towards the solutions to these issues in the tax system, in the health system, in the retirement system that we have to get, and far beyond that. And the mistake, I think, that I believe, is to define away certain issues as not being important. That's the mistake. And the reason, again, as I say it's the mistake, is because where I started, is I think we have a system that increasingly takes democracy away from the public. It tries to let all of us, whether we're conservatives or liberals, to try to foreordain in the budget and our tax cuts, our spending increases, what the budget will be 10 or 20 years from now, and take away from people the right to decide where that spending, where those taxes should go, and how they can best meet the needs of the time. Thank you.
Well, thank you, everybody. It was very interesting. Let's see if we can get a little more of a debate going, though. Everybody's much too nice to one another so far. Dr. Rivlin said that this isn't an either-or situation, and we ought to be able to do all those things. But I see Charlie Stenholm here. I see John Breaux here, who can probably attest to this. It's very hard for Congress to do more than one thing at a time. In fact, it's very... That's only the Senate. It's very hard for Congress to do one thing at a time.
They can't even agree on this.
So the question, I think, still is where we started, which is what do we do first? Do we focus on Medicare? Do we focus on payment systems and efficiencies in Medicare first? Or do we say, no, that's really not a productive use of our time. We really should be spending our time dealing with the real question, which is overall health care reform. So let me ask each of the panelists in turn, and maybe since I sort of started this with Alice, maybe ask her first. Which do we do first?
As I indicated, I would start with, and Medicare has already a little bit started. They have a toe in the water. I would start with using Medicare to lead the way toward more effective, evidence-based care. And that's going to take collecting a lot of information and analyzing it. And Medicare is in a position to do that. It has a lot of information, not always in the right form, but you can learn a lot, and indeed a lot has already been learned about what's effective and what's not from the Medicare database or an improved database. I would definitely start there because we know how to do it. And start changing the Medicare reimbursement rates to reflect what is learned. That doesn't mean we shouldn't start on other things, but that's a no-brainer. Let's do that first.
Henry, do you agree?
Yes, but I would like to add a few items to the agenda for the next year. The first, and I realize that one is swimming very much upstream here, I believe both presidential candidates have embraced extension of more of the tax cuts than is prudent from the standpoint of our long-term budget health. On this score, my own view is that Senator McCain's call for still further tax cuts is really a step in the wrong direction, but Senator Obama might serve the nation better if his election prospects worse if he did not support as many of the taxes continuing as before. With respect to health care, I think Alice is exactly right. It seems to me there is a severe risk next year if Senator Obama is elected president that the Democratic Party might once again overreach in going for excessively more sweeping health care reform than Congress or the nation is prepared to embrace at this time. So it seems to me that it would be prudent, in addition to the step that Alice described, if Congress undertook some practical short-term steps toward extending coverage rather than a sweeping overall reform. Finally, and playing against type, I believe there is a deal to be struck on Social Security reform if people from the political center, the kinds of gentlemen who are sitting here in this room, some of whom still remain in Congress, sat down and worked together to form a reasonable compromise plan. I think it's doable, and it would do enormous good for the nation, for confidence in government, and for our long-term budget situation if we put the Social Security financing problem behind us.
Maya, Medicare first?
Thanks. Ooh, double. I think the most important thing is to stay open to whatever the political opportunity is to go first, to go first. There are a lot of different ways that this could unfold. I think the two principles to remember are, one, it's going to be hard, and two, it has to be bipartisan. So I don't think that trying to sell any of these reforms as relatively easy to do is helpful, because the bottom line is that this is going to take sacrifice. We haven't been talking about sacrifice much in the past couple of years. All fiscal reforms that actually make a difference are going to be hard. It's not as though people aren't going to feel that. That leads right into the necessity for it to be bipartisan. You cannot expect one party to push through anything that is hard on their own, because we are in way too hostile an environment for people to expect that to be appreciated. And I think given how hostile the environment is, it's going to be tough for the reforms to be as big initially as I think they should be. I think we should push for having as much change as possible in one fell swoop, because I think reform comes in waves. You get some reform now, and then we sit back. Most of the country thinks we've fixed it when we haven't, and it will be a while before there's another opening. So stay open to all possibilities, whether it's Medicare first or a Social Security deal that leads into health care. But if I could see this unfold in any way I wanted, I would hope that the next president calls for a budget deal. The budget doesn't focus on when do we balance the budget. But balancing the budget does matter, but I don't think saying, oh, we'll balance the budget by 2015, for instance, would be as important as saying there's a long-term fiscal goal we're going to shoot for as a country, and that's, say, cutting the fiscal gap in half, something like that. And I think in order to do that, you need to work in changes to discretionary spending, additional oversight, what programs are outdated and not effective, hopefully have a full-fledged Social Security deal. Retirement age would be kind of the central piece of that, something on slowing the growth of spending for high-income retirees, maybe something on revenues, lifting the cap for the payroll tax in part, and then as much of health care as we can put out there. I disagree with Julie that anybody knows how to fix the problem from health care right now. I would gratefully challenge anybody, put out a plan that would control health care costs enough to close the gap. I would say let's take as many ideas as there are, wrap them into a budget deal. There will still be more to do. We'll come back and look at that later. The final piece I would put out, in thinking about what the presidential candidates are talking about, there is a lot of agreement on some good ideas that then are usually offset by more ideas that would make the deficit worse. But both candidates are talking about cap and trade. I think looking at energy revenues as a way to help fill in the gap is something that might not yet be practical, but is a really smart way to move forward. I think the health care saving ideas that they have is certainly something that they can come together on. There's a lot of overlap there. And I would agree with Henry. Both candidates are actually talking about more tax cuts on top of making the tax cuts permanent. I would stop. I would say no more digging the hole until we've come with some kind of budget deal.
Julie, Maya says not so easy. You say easy.
No, we never said easy. We said possible. But we agree with Maya in a couple of different ways. We have to deal with the political reality as they come, right? So we understand that these things are going to happen as much as we are hell-bent on comprehensive health care reform. That comprehensive health care reform will come in waves. So that's just true. And what we know about the political reality at the moment is that S-chip is most likely unlikely to happen, never say never, but not this Congress. So what's the first thing that's going to happen? S-chip in the next, and that will be the first thing that is probably the success of both parties, and they can hold that up and wave that flag. And that's a very good thing. And unlike Maya, we do not think that that is going to take the political wind out of the sails for health care reform. We think that's going to be built upon that success, that bipartisan, yay, rah, we can do this for the right reasons.
Julie, can I interrupt for a second?
Absolutely.
I want to, I mean, S-chip seems to be going the other way. I mean, S-chip is spending more money. S-chip's easy for most politicians to do.
Right.
I'd like to get you back to the other issues, the issues of how are we going to reduce costs in a prudent way while covering.
Right, well,
providing the care for
and the question is, what do we do first, right?
Right.
And so I was answering the question, we start with, unfortunately, probably, what's politically easy, and then we move on what is more difficult. And I completely agree with Alice Rivlin that we are going to be looking at Medicare reform in order to start on comprehensive health care reform, because, as actually Henry Arendt's health affairs piece on this subject points out, these are the same health care providers treating the public sector and the private sector. If we have payment reform and delivery system reform starting in the Medicare, which we have already begun with these pilot projects and private pilot projects across the country, that's where we're going to begin to bring the health care costs down for the entire health care system.
Bob?
Well, if the question is what ought we to do first, I think if we start with a point that I think we all agree on, that the single biggest driver are rising health care costs, then whatever you need to do up front to start to put you on a path to slow rising health care costs, plus any areas of the budget where we're about to hit a tipping point, where if you don't act in the next year or two, the opportunity may be gone and huge costs may occur for years or decades to come. So I think that leads to the following conclusions. Number one, we have got to start to put in now infrastructure to give us answers and tools to slow the rate of growth of healthcare costs over time. That would include comparative effectiveness research, health information technology, and, as a number of people have talked about, those kinds of changes through Medicare and delivery systems that have hope of yielding savings both in Medicare and later in the healthcare system as a whole. Since all these things are going to take time, we ought to get started right away. Secondly, within Medicare, we are almost at the tipping point with regard to the huge overpayments going to private insurance companies and Medicare Advantage. If we let about 2 more years go by without acting, it's gone. You can never put that genie back in the bottle for political reasons. So we've got to act, I think, on the MedPAC recommendation regarding Medicare Advantage. Thirdly, obviously, tax cuts have to be dealt with between now and the end of 2010. Not that I think this will remotely happen, but to give a sense of what's at stake. If you do a fiscal gap projection through 2050, you find that and if you use a baseline where you assume the tax cuts are extended, what you then find is that if you adopt a regime where any tax cuts that are extended have to be paid for, whether it's on the tax or spending side, over 50% of the fiscal gap through 2050 disappears because of the big compounding effects on interest payments on the debt. Now, no one in the room thinks we're going to pay for all tax cuts we extend, but it gives a sense of the magnitude of the decision as to how many tax cuts to extend and how many of those to pay for or not to pay for. Last point, which I think should be required reading for any of us concerned about deficits, is an article, and I think it's last month's Bulletin of the Atomic Scientists by Gordon Adams, about how he argues in coming months, maybe the next year, there actually is a critical decision or set of decisions that will need to be made about the trajectory of the defense budget, and that contrary to the easy assumptions that there will be big savings as we withdraw from Iraq, that there's a potential for a long-term explosion of the defense budget if the next administration, whoever wins, doesn't get a handle on it early on. So I think those are the areas of greatest urgency.
Gene, Medicare or overall health care reform?
I'm going to speak as if I'm advising the next president, which might be different than what I would do if I was advising a member of Congress looking for a particular point of opportunity. I think when a new president comes in, he or she has a unique opportunity up front to get one package through, particularly if his party controls Congress, because they will pass something, at least symbolically and hopefully real, that will back him on those items. And there's an old paradigm that I don't believe works anymore, which is you go for a victory now, so you prove to the press that you can show that you can make things happen, and then you work off that victory towards the future. I don't think that works in this case. I don't even think such a thing as a modest Medicare or Social Security reform or a $500 billion over 5-year type of budget agreement works. And I sense the public is searching for a new paradigm, a new way to define the issues. And I think when I go to the president is I'd first say, look at these numbers. Just look, if you think you're going to last 8 years in office, within about 5 or 6 years, you've got no flexibility whatsoever. Social Security, Medicare, and Medicaid, plus even a more modest defense budget, totally uses up all your revenues. You are really in a box. And even if you get a 1 percentage point of GDP, which would be huge, by the way, by past standards, right, when we think about modern budget agreements, even if you got that much out of a package, that's not enough. You've got to figure out a way to present to the public to deal with the long-term budget before you deal with the short-term budget. And I'd submit that a number, not all, but a number of the fixes that people often propose are, well, what can we do on the short-term budget? And as long as that long-term budget's out of balance, you're always back in the soup. That's, as I was mentioning in my original talk, never before in our history we're in that situation. Historically, you've got, the short-term budget was often out of balance. We had all sorts of problems, but the long-term budget was in balance because the revenues always grew faster than discretionary expenditures and you're always in balance. Now we have the opposite. The long-term budget is always in imbalance. And I think we need a budget process that basically says we're going to address this long-term budget first. And that means everything, and we could debate about what, whether you're using commissions or presidential proposals or requiring Congress to act on certain things. In terms of the process, I think it also requires totally representing the numbers. If I was the president, I would not present the budgets according to this thing we now call current law that nobody understands, that doesn't distinguish between the growth that comes from, say, the entitlements and the growth that comes from discretionary spending, because then it hides from the politicians the responsibility for accepting that growth. And I'd build them both in together, that the growth in the entitlements that's mandatory versus the growth in discretionary that you want, you've got to count them together. And I would really work toward that type of solution. And then I'd work backwards to what that means for when you do Social Security reform and Medicare reform. And I've already talked too long. I'd like to engage this issue of how far you can go with these efficiency gains in Medicare and the health system, but I've already spoken to
you anticipated my next question. Julie raised this in her presentation, which is the idea of wasteful or inefficient healthcare spending and how much can we do to get at that. I think there's a general consensus that there's a lot of it, although I hope Henry can talk to us a little bit about perhaps some of the definitions that people use about what waste means. But I think defining it is as difficult as defining it is. I think doing something about it is even more of a challenge. And the question I kept thinking about when Julie was talking about this is, so who is it exactly who tells me I can't have that knee surgery that I want? So I wonder if each of the panelists wants to tackle this, and maybe we can talk a little bit about how much waste there is really out there and how much of it we could expect to get. Henry, you want to start?
Everybody here would agree, I think, that if we spend money for an intervention that does no good at all or does harm, it's wasteful. But now we get to, that covers some of what the healthcare system does, but not really very much, and arguably not an increasing share of healthcare spending, and therefore arguably not any factor at all in the growth rate of overall healthcare spending. Where we run into the interesting and hard problems is when we look at interventions that cost a great deal of money but are acknowledged to provide some benefits to some people some of the time. I suggest anybody who's interested, get on the web and take a look at a site at Tufts University. If you can't find it, send me a note and I'll give you the URL. That reports on the literally thousands of studies that have been done of the cost per quality adjusted life year added. They range from a few dollars to millions. Where do you want to draw the line? And what is the institutional framework you want to put in place that will permit some entity, physician, hospital, government, you name it, to draw that line? That's the real challenge that we face in thinking about squeezing out high-cost, low-benefit care. That's really where the money is. So I think there's a lot of loose talk about waste in the healthcare system, and there is lots of it. I'm not questioning that. We spend more to produce services than we need to in many cases, and that is sheer waste. But the real issue arises from the constantly expanding list of beneficial interventions that are very expensive, that help some people some of the time, and that, as a nation over the long run, we really can't afford for everyone. That's the challenge, and I don't think that much of the debate about waste has come to terms with dealing with that problem. It's formidably difficult. I can't think of a more difficult issue for a democracy to confront, but it's the one we're going to have to confront over the long haul if we're significantly to rein in the rate of growth of healthcare spending.
Julie?
Yeah, I can get less friendly now. First of all, a third of the spending that's on unnecessary care, that's a number that comes from a 2005 report from the National Academy of Engineering and Institute of Medicine. So this is not a fluff or throwaway thing, and it's been something that's been confirmed by Dartmouth and Stanford and others. But, and by the way, that a third of U.S. healthcare spending that's on unnecessary care represents 5% of the GDP. That's how much money we're talking about. We can cover all Americans for 1% of the GDP. So, reducing merely 20% of the unnecessary care would enable us to absorb all of the rest of the uninsured in America. So, first of all, real money. Second of all, real example on how we can make efficiencies actually solve this problem. It's not, when we talk about waste in the healthcare system, we're not talking about rationing. If you want to talk about rationing, we should talk about capping entitlement programs, because that's when real rationing would start to happen, when we say, oh, we're done because we've met a dollar amount, now you can't have X. That's rationing. If you want to talk about getting efficiencies out of healthcare, I have an example. There was a medical home that was created in the North Carolina Medicaid program. Patients were assigned a doctor, and they had this health home through a local community clinic. They're assigned a physician that works with social workers, nurses, therapists to manage the patient's care. Part of our major problem is that we have silos of care that do not talk to one another, so we have duplicative tests, duplicative treatment, and so forth. So these doctors were paid $3 per member per month as an incentive to effectively coordinate care. In fiscal year 2004, North Carolina, under this program, saved $244 million. They found similar savings in 2005 and 2006, and that savings represented 11% of all the Medicaid spending by the state of North Carolina. So that's real money, and that's effectively managing care.
Gene?
Like any industry or economy, we always want to favor efficiency improvements. The healthcare sector of the United States probably is about as big as the economy of France. And if we ask where the economy of France is going to be 10 years from now, do we want it to be more efficient? There's probably a lot of suggestions we'd make along the way. But that doesn't tell us how to govern the economy of France to get there. And it doesn't tell us, I think, to talk about efficiency improvements, necessarily to tell us how to govern healthcare economy. If you look at the two extreme positions on healthcare, they actually do operate within a budget. The one extreme being, let's just have individuals pay for their own health care, and they'll make discrete choices, and they'll stop buying care when it gets really expensive. And that's right, they operate within a budget. And the other extreme position, which is sort of a Medicare for all, where the government supposedly operates with a fixed budget, that does have a budget. So if you think about it, the people who advocate these extreme positions implicitly do recognize that there is a budget constraint needed. But when you deal with the type of hybrid system we're inevitably going to have, where we're going to have a Medicare and a Medicaid, and who knows whether we're going to have a Part E, F, and G of Medicare, we're going to make all sorts of changes over time. Every one of the parts of the system needs to operate with a budget constraint. The health tax exclusion needs to have a cap. We can debate whether that's going to improve efficiency 1% or 10%. I'm not going to argue it's going to improve it 50%. That would improve efficiency. If we think we need to have I worked for 4 years for the National Committee on Vital and Health Statistics, working on electronic health records, which is another one of these efficiencies, which, by the way, I favor. It's going to improve health care, but we don't even know whether it's going to reduce health cost. But there's choices you could make. I mean, Medicare today can say, well, it actually has recently done some changes, which I tried to push for a number of years. It can say, we're going to pay less if you don't e-prescribe, and more if you do, and you could do that in a budget-neutral manner. We can empower Medicare and to come up with rules just to stay within a budget. It's the lack of a budget constraint that won't force some of the hard choices. I like the way that Henry teed them up, won't force some of the hard choices that you face. In my view, you can't have open-ended systems, whether it's a tax exclusion, a Medicare system. Open-ended, I mean that basically any health care comes along at any price you get. And finally, to your question, Howard, about denying care, I think in the end, we're probably not going to be very good. There'll be occasions. We're not going to be very good at denying particular types of health care, but we are going to say, you know what, those knee surgeons, as we look out there, they're making pretty good money. I'll bet we could pay $4,000 a surgery instead of $6,000. And I can't remember, I think Medicare did recommend something like this recently. And we're going to start forcing a lot more decisions like that to be made, one at a time within budgets.
Alice?
I would start with the easy stuff first. And I think two areas are, let's analyze why it is so much more expensive to have a heart attack in Miami than in Minneapolis, even though the recovery is no different, and how we can get Minneapolis to be more like Miami in terms of guidelines for what you do. No, I'm sorry. I said it wrong. I'm sorry.
That's good. We like Minneapolis. Sorry.
To Miami be more like Minneapolis, I'm sorry. And the other is extending life in situations where no recovery is possible. We know there's a good deal to be saved there, and we have to figure out how to do that. And there's a long way to go before we say, Howard, you can't have your knee surgery.
Bob?
We'll get there, but...
Yeah, well, I essentially echo what Alice just said. I think we know there are these big inefficiencies. We have the data on the differences in costs in different areas, but we don't have the base of knowledge right now to be able to have Medicare and private payers say, okay, here are the 10 things we're doing to dramatically reduce those differentials. And to the degree that we think we may know what some of those are, if we tried to eliminate payment for some of them, we'd get big reactions from doctors, from other providers, and from some patients. So I think we badly need a stronger evidence base that really can put us in a stronger position, both analytically and politically, to then be able to say we're no longer paying for various kinds of things that are less effective, both through Medicare and through private insurance.
Henry?
I just want to add one point. I think I can think of a lot of reasons why it would be a good idea to make Miami more like Minneapolis. But I'd like to make this problem a little more complicated even than it is. We do know, as Julie has pointed out, that we do vastly more aggressive medicine for heart disease in some areas rather than in others. The Dartmouth Medical Atlas has detailed this. We also know that on the average, health outcomes, where we spend a lot, are not materially better and in some cases are worse than where we don't use high-tech medicine as much. That's the background. Along comes a young professor at MIT named Joseph Doyle, who has a really bright idea. He said, you know, people don't have heart attacks on a discretionary basis. Let's take a look at what the health outcomes are for people from outside the region who suffer heart attacks in high and low spending areas. Alas, for the simplicity of the argument, the people who are there by accident, randomly, presumably entering hospitals because of their illness, do better in the high spending regions than in the low spending regions. Now, how does one reconcile that with the other finding? At the very minimum, it says we've got to be very careful about drawing sweeping judgments from average information that lumps together very diverse people in particular areas. A lot can be going on that explains the particular patterns that Julie pointed to correctly from the literature. I've read the same studies. I didn't mean to be. No. I agree. They're really important studies. But take a look at this study by Doyle. It is one of the more disquieting pieces of information you will come up against, because it suggests that one of the possibly easy fixes, simply discouraging physicians from using expensive high-tech care aggressively as a way to save money without loss of benefit, may not be correct.
I think there's an interesting case study out there we all ought to be watching, which is this whole matter of PSA tests. I'm sure you all saw there's stories recently about, there's a great deal of data now which suggests that these are at the best not productive and at the least actually quite costly and not good for people. And I think it's going to be interesting to watch the lobbying that goes on should Medicare decide it's not going to pay for these for people over 75 years old. There's going to be a good story for somebody to do here. Maya, did you want to just weigh in on this, and then we'll open up to questions?
I mean, I think I have no gripes or inside knowledge on whether the one-third number is correct or not. I think it probably is. I think the problem with focusing on waste in anything is that we so regularly don't know it until after we see it. You know, we all know that so much of healthcare spending is in the last 6 months of life. We also all know we don't know when that last 6 months of life is. We all know that we feel very different about how healthcare should be treated when it's, you know, you out there that someone else is paying for, or when it's your mother or your child. And the problem is that we're going to have a discussion about how to make healthcare more efficient and how to change the system, while also bringing in the highly personal terms, which end up dictating how we all feel about it in the moment. My concern is there is real savings to come from this part of healthcare. It will, as I keep saying, you know, not make this a painless reform. And I don't want this to become the new waste, fraud, and abuse of the budget. I don't want this to become the new tax cap of the budget. We are always pointing towards something which is magically going to fix the problem. And those things make great talking points, but they don't make good legislation. If there is anything painless out there that will improve the efficiency of the healthcare system, by all means, I think every single one of us agree, let's put it in the big budget bill that we have to get on top of this problem. But bottom line is we know that it's going to take more than that, and it is very hard to define what waste is, particularly when you're dealing with something as personal as health.
I'm going to turn it over to the audience for questions in just a second, but I just want to just sort of conclude this part with just a quick anecdote, a dreaded healthcare anecdote. Woman is admitted to the hospital, 94 years old, from a nursing home. She has stage 4 lung cancer. She has congestive heart failure. She's stabilized, put into the ICU, and very early in the morning, she meets with the physician, the charge nurse, the social worker. And they have the following conversation with her. They say, you're very, very ill. You have 2 choices, really. One of them is we can keep you as comfortable as possible, and the chances are very good that you'll die within a day or 2. The second choice is we can put you on a ventilator. And here is a little bit about what your life will be like on a ventilator. And you probably live for a month or 2. What do you want us to do? And she was cognitively completely intact. And she said, I want the ventilator. And I think the interesting question as we talk about getting waste out of the system is how are we going to change the way we have that conversation? And are we in the United States in 2001 going to say to her, sorry, you don't get the ventilator? And I think those are the kinds of really tough, as Maya said, personal questions that we're going to have to confront sooner or later as we look at this. Okay, let's open it up to questions from the audience. Yes, sir.
As one of those people who will be...
Could I ask you to please identify yourself, use the mic. Thank you.
My name's Dwight Bartlett. I'm a consulting actuary and former chief actuary of the Social Security Administration. As one of those people who won't need PSA tests anymore, glad to pose a comment and ask for a response. It seems to me the very first thing that needs to be done is we got to create the political climate that makes any kind of reform possible. And I believe that what needs to be done is to educate the public both about the cost of health care in general And I think the public really does understand that already. But what the public doesn't understand, in my opinion, is what lousy results we get for the very expensive healthcare system we have, measured in terms of life expectancies and infant mortality rates compared to those in other rich nations. And I wonder if the panel would comment on that thought.
Let me actually refine the question a little bit. Whose job is it to educate those people? Is it the government's? Is it doctors? Is it journalists? Whose job is it? Anybody want to?
Yes, to all of those. But let me challenge one of the premises of the question that people do understand the cost of health care. They don't. Most people don't understand that on the average we pay out of pocket at the time of illness for 12 or 13% of our total health care spending, that percentage has been going down. The primary problem with the cost of health care, as evidenced in public opinion polls, is that I'm be asked to spend too much for health care. And so I think there's a disconnect between the facts regarding the out-of-pocket exposure that people face when ill, and a recognition of a recognition of what the cost of care is. It is really important that that level of understanding increases, and it's easy to say we have to educate the public, but apart from a continued effort by journalists, by scholars, by elected officials to drive home those points, and those efforts are going to be counteracted, incidentally, by various groups who may find it adverse to their interest to have an increasing awareness of those facts. Aside from that, it's a long, slow process. I hate to be anti-democratic, but in the end, I think it is more important for elites to come to understand these points in a general way and form a consensus and encourage elected officials to take some chances and on the initiatives that they will end up supporting.
Gene?
I'd like to suggest that when we come up with these one-off solutions to particular cost savings or efficiency improvements in healthcare, that even if they reduce cost in the specific instance, they don't solve the problem and they don't actually even necessarily reduce aggregate cost. In some sense, it's like pushing on an air in a balloon. If you push on the air in the balloon and it just is allowed to pop out somewhere else, you may not win the battle. So an example that someone close to me gave recently was the latest they've moved a lot towards generic drugs in chemotherapy. But what has happened is the latest chemotherapy cocktail now costs about $100,000 a year, as I understand it. If you would come up with some new improvement to push more generic drugs, and all the drug company has to do is say, well, now for our new cocktail, we're going to charge $120,000, and we're going to justify it because we're still covering the cost of these same scientists and workers in our firm, or however they justify it. You might have pushed on the air in the balloon. You might have gotten some efficiency improvement, but you won't get there. The language of politics is the language of winners and losers. In an open-ended system, you're facing the dilemma that you're always forcing the politicians to identify losers. With your examples, the PSA test. If you have a constrained system, then the politicians can identify winners, and sometimes they can justify themselves to the lobbyists by saying, I gave you more than you wanted, but I didn't give you everything. And you also then force the battle between the people who want education versus want the $120,000 cocktail. If you don't put the constraints on the system, I think all the discussion on the efficiency improvements, I think you'll get some improvements, and we've had a lot of improvements. DRGs were improvement. We'll get some along the way, but you've got to do this within a constrained system. And if you're not willing to deal with that part of the issue, I think a lot of the discussion, all these great efficiency improvements, which is, I say, like in the economy, we're going to have forever and ever opportunities. I think we don't really solve the problem.
Senator Brown.
Thank you, Howard. Excuse me. Thank you, Howard, and thank the panel members. I had the opportunity this morning to chair a panel on comparative effectiveness research. We had Peter Arzig from CBO Director, we had Mark Miller, MedPAC Director, we had Liz Fowler, who's Chief Counsel, Health Counsel for the Finance Committee, Marilyn Moon, and some others. And the question is about how to go about establishing a comparative effectiveness regime for this country. And whether it's an advisory commission or whether it's with an existing federal agency, whether it's through Medicare, or how would you go about doing that? And the legislation that has been introduced, Liz Fowler was explaining to the group assembled, that they would establish an independent commission and to look at all of the means of effectively treating people around the country, but that they would not consider cost. And I'm wondering if anybody on the panel has a comment about that. I mean, is comparative effectiveness research of any value, or is it incomplete if it doesn't also consider not just what is the most effective treatment, but also the cost of those effective treatments as well?
Alice?
I'm an economist, and I think you have to know the cost. Otherwise, it's pretty meaningless.
I'm not an economist, and I agree. I think, and we know about that the plan that Liz Fowler is talking about in the Finance Committee, and we're gratified to learn it's being discussed elsewhere. But I think she doesn't just mean that they are only going to compare the effectiveness in terms of health outcomes. I think that is the first order of business. And I think what we really need to be concentrating on is putting those decisions in the hands of the right folks that we can all agree as a society need to be making those decisions in response to whether or not we put the young lady on the ventilator, and the question put by the moderator. I spent a couple of months inside a health insurance company on loan by my law firm as in-house counsel, litigation department. It was a blow your hair back kind of a position. And on my very first day, I wasn't there for 30 minutes before I got a call from a medical director that I was in charge of in one of my regions, and she called and she said, we have a very similar to Howard's scenario. And she literally asked me, the hospital wants to pull the plug, the doctors and the family do not. We're the insurance company, we get to decide whether or not we're going to continue to pay for this care. What should we do? And I was younger than I am today. So that was a really interesting problem. And I think what I came away from that, and one of the reasons why I'm not litigating right now and I'm trying to do policy instead, is because I don't want to be the one making those decisions. I don't think that's the proper place for those decisions. I want to make sure that one of these independent commissions with the right professionals are making those kinds of decisions. And so yes, they need to make the decision about whether it's the right health care first, but all things being equal, if we had this is just as effective and this is just as effective, but this costs $100 less, you do the $100 less. That's what the commission should be doing.
Anybody else want to tackle that one? Henry, you want to?
The hard problem is that you cannot come up with a procedure that falls outside the examples of pure waste that I defined before that doesn't help somebody. And it doesn't help somebody, and it fails to help somebody else. The problem is that ex ante, you can't know for sure into which category a patient falls. It is for that reason that I think it would be a dreadful mistake, except in very particular and unusual cases, for decisions about availability to be flatly determined by some commission away from the bedside. Inevitably, these decisions must be made in the context of the delivery of care by medical professionals and by individuals. That said, the circumstances in which those decisions are made will be heavily shaped by resource availability. Let me give you an extreme example from some work I did a long time ago on the United Kingdom, where at the time, if you were over 50 or 55, you just would not receive dialysis. There were dialysis centers. Not one of them had a queue. There was no waiting line. Not just because renal failure is quickly fatal. The real reason was that the physicians who refer patients to the clinics for examination know what the resource availability is, they know what the criteria are that have been adopted, and they make the decision in advance. They would tell somebody who was 60 years old with renal failure, I'm sorry, there's nothing we can do for you. We can make you comfortable. As in this situation, the very information about dialysis would not be transmitted to the patient, as would have been the case in the example you described if there was a limitation on ventilator capacity in that hospital and somebody 25 years old who had suffered injury in an automobile accident but could be expected to recover completely was using that facility. So it's really important that I think the principle of that actual medical decisions are made in a clinical setting by physicians and their patients be retained. But Jean is absolutely right. Those decisions are conditioned by the overall resource availability governing the system as a whole.
Let me ask Bob Greenstein about that. Should there be caps? Should we, in the wealthiest society in the history of the planet, cap the amount of resources we spend on?
Pardon me, let me intercede at this point. I didn't say that we should have a cap. I said that if you're going to have limits in that kind of a situation, there has to be some form of external restraint because if you get down to the patient-physician setting and there are not such limits, the care will be provided.
Gene has talked about caps, though, so I want to get...
I just want to be clear. I consider things like DRGs cap. I mean, you got to define cap. There's a question of overall caps. Are there constraints you put on particular parts of the system? Attempts at things like DRGs, and there's attempts to put on higher levels of services. Those are caps. A cap on the tax exclusion is... So I'd be careful when you use the word cap. I'm not talking about necessarily some overall cap that just...
I understood.
Or cap on number of people who receive benefits.
Now, with all the caveats, Bob, would you like to respond?
Given the caveats, I'm not sure what the question is. You know, one can conceive of a system like some countries have in Europe where there's a global cap on healthcare costs system-wide in the context of a single-payer system, but that isn't going to happen in the United States. I also think that certainly I agree with Gene that particular things, DRGs and other mechanisms like that, mechanisms that can deal with particular kinds of excesses imposed initially in Medicare and then picked up throughout the healthcare system would certainly, that's what we've all been saying, part of where we need to go. I think there are very serious concerns about, instead of doing those kinds of very difficult comparative effectiveness research, finding the individual things, DRGs or others, the MedPAC recommendations, to instead wave that to the side and say, we're just putting an entitlement cap on Medicare, end of discussion. A, wouldn't work politically. It would not be sustainable. I do not think you can sustain a system in the United States where healthcare costs per beneficiary in Medicare year after year grow at a slower rate than healthcare costs system-wide. And people like Gene's boss, David Walker, Peter Orszag, Gail Walensky, I think most healthcare experts I know of agree. You could not sustain that over a period of time. If you tried to sustain it over a period of time, you'd have much more of a two-tier healthcare system than we have now, with greater disparities by race and income. So all of this gets back to the question that we need to have remedies that address healthcare costs system-wide while recognizing that the Medicare delivery system is one of the key mechanisms through which to try to introduce changes that then flow system-wide.
But We also need to think about patient incentives, which is one of the things that I feel like the debate used to kind of focus on years ago more than it does now. I think in response to Senator Bro's question, of course one has to think about cost, because dollars are a part of this. It's not just the comparative effectiveness, it's the cost-benefit analysis. And the same is true for thinking about cost when it comes to the participants in the healthcare system. This solution is going to be both a supply-side solution and a demand-side solution. And there's no way to kind of leave out the piece that people have to be more aware of the cost of the healthcare procedures that they're receiving. Now, that's very different when you're comparing, again, kind of disease management, high-risk healthcare, or me overreacting and bringing my toddlers into the doctor for bug bites every summer, as I do. We have to recognize that people should have different levels of cost sharing for different kinds of healthcare expenditures. But I just feel that there are so many different pieces of the system that have to be addressed, and a major one of them is, as we all know from being patients, linking us to the direct costs of the healthcare expenditures that we expend.
Mr. Stenholm.
The question for the panel is, does anyone on the panel believe that we will solve any of these problems within or without the budget process without putting everything on the table to begin the discussions? One of the problems politically is always everybody's for doing it in somebody else's shop, but let's not talk about X because that is off the table. Secondly, since 2003, I have been very interested in a simple data analysis to answer the question in simple anomalies, not preconceived conclusions, as to why Iowa delivers health care to their Medicare and Medicaid recipients at roughly 50% of what it cost us in Texas. And we've never been able to get anyone to look at a simple analysis of the data that's available and to answer that question. And it seems to me that if you could do that, just the anomalies, that you might have some of the other answers to the questions of how you reduce the cost, because I don't believe Texas has a 50% better health care delivery system than Iowa, or 50% worse in Iowa than Texas. But I've never understood, other than the stovepiping and the analysis, and everybody believes we've already done it 10 dozen times, but we still don't have a simple answer for Iowans and Texans.
Let's look at... Anybody have any idea?
Well, we can send you some information when we're done here. There is information out there, but I mean, I guess I have a couple of responses. There are disparities in healthcare across the country, and there's disparities in the cost of healthcare across the country. And the answer is complicated as to why that is. But mostly, Senator Bro's point about having a comparative effectiveness commission, public-private collaboration will help us answer a lot of those questions, because what they will do is they will study what is going on throughout the country, share that information to decide this is the proper thing to do in this scenario when a patient presents with this diagnosis. So once we have that, then what happens in Texas with that presentation of that person is going to be the same thing that happens in Iowa. Now that's just part of the calculation, because of course Texans are not Iowans. And so we have disparities in who they are presenting. So in the South, we have a higher rate of diabetes sufferers than we have in, say, Minneapolis. But the kinds of things that we can compare apples to apples, like when a mom presents with a high-risk pregnancy and she gets a cesarean section in one state but does not have a cesarean section in another state, what was the proper thing to do? Because one costs a heck of a lot more than the other. So there's a disparity in healthcare and costs that we can only address if we're doing some of these studies that we need to do and sharing the scientific information, because we've never had an electronic healthcare system to rapidly exchange this information so that we can drill down and find out what's going on. So that's the first thing we need to do. And the second thing, in response to your concern about the Senate can't do more than one thing at one time, that may be true, but what's exciting about what's going on in the Senate right now is that the Budget Committee and the Finance Committee with Liz Fowler and the Help Committee are all working together to come up with some of these solutions to the very complex problem of healthcare. And we have been gratified to learn that they're actually working together on that problem, and we're, along with many, many others, helping them do that. So are we going to see it's all on the table next year? I think so. That's what we're talking about. There's certainly hope for that.
Sorry, let's take a question from the back. Yes, sir. Hang on just a minute. We'll get your mic.
I really appreciate the...
Could you introduce yourself?
I'm Paul Gianandri. I'm on medical faculty at University of Maryland School of Medicine. I really appreciate the suggestions about how to deal with medicine and how to conduct medical procedures and everything. But isn't the problem a little more basic, and that is responsible spending? I mean, the issue is, I talked to my 14-year-old. If I gave him a credit card, that would be a mistake because he'll deficit spend. And the problems that we're focusing on now are problems that are already where the problem seeps out into and becomes a national crisis. But where is the responsible spending promoted and helped and assisted in that? You know, if I have the credit industry, the banking industry, you know, it's not just about health industry and Social Security. It's about where do we teach fiscal and responsibility to our kids. You know, is it a family issue? Is it a public issue? Is it a national issue? I mean, I think that by the time we've finished and fixed the medical system, we'll have other systems that are going to go out of whack, such as energy and energy conservation. Where do we teach that? And I think really patient education is one thing, and then children education about responsible spending. We have leaders who, you know, deficit spend, and then who covers the deficit. See, we all have shared responsibilities.
I think you probably want to talk to Gene Sterling about that. Gene's doing a lot of work on educating people, and so is Maya. In fact, so is everybody on this table about educating people on spending. But I think you raised, I mean, you rang a bell with me, responsible spending. And I think that's what we're trying to talk about here all afternoon, is what is responsible health care spending. Gene, you want to try to answer that?
Can I just add that responsibility comes with having to face up to the responsibilities. You know, like several people, Bob in his recent comments noted that, well, he didn't see how health care could not rise above some particular cost. All that happens if you put different parts of the system, and they might not be the parts we like, but they're the parts that are there. We put the different parts of the system into budget constraints as we simply force Congress to vote on the increases. That helps solve some of my political dilemma about identifying. It's easier, I think, for Congress to limit an increase than it is for them to cut back on something people that think they've already been promised. It doesn't mean that healthcare spending would rise less fast than GDP, just as we don't wage index teacher salaries, but I want to increase teacher salaries, but that's part of a discretionary budget. So I think putting things into a budget doesn't mean we don't vote to change them over time. In fact, it makes us more adaptable to make the changes. And among the changes are not just between healthcare and everything else, which is getting crimped, but it's within healthcare. You know, the government is now spending somewhat in excess of $11,000 a household. You add total health care spending by the government. By number of households, it's already in excess of $11,000. And we say we can't afford to get sort of a health insurance for children. It's easily affordable in the increments in health spending we get, but because they're built into the budget automatically, we can't even have that discussion within health care to say, okay, if we're going to increase the health budget, where do we want to spend the money? Do we want to spend it on preventive care? Do we want to spend it on children? We can't even have, I don't see how we get those debates ever formed unless we have the budget. But it doesn't mean the health care is going to increase in cost over time, or that it might not increase faster than GDP. That's going to be determined over time.
Yeah, I would never be somebody who says that budget process is going to solve anything. It's not going to solve much of anything unless we have a political will to really tackle these issues. But there are some fundamental starting points which really need to be changed, and two of the big ones have been mentioned by Gene and Bob here. So one is what Gene was just talking about. We need to think about how our baselines work, what our starting assumptions are, and so that we can reframe when you look like you're spending more or you're spending less. It's a lot easier to set a starting point that lets Congress come forward and say, look, we're going to cut your taxes and raise your spending than the reverse. And we actually have the power to change some of our budget mechanisms to allow that. Another critical point is just this basic working operation of PAYGO, which Bob brought up, and we're actually 2 of 4 groups that have had something called a PAYGO pep rally in this very room. not as crowded as this, but you know, there are a lot of us who think that the fundamental principle of if you're going to spend more, you have to find a way to pay for it, either by raising taxes or cutting spending, won't fix the problems that we currently have, but it will really stop us from making the situation worse. A project that the Committee for a Responsible Federal Budget is running called U.S. Budget Watch, we just put out a voter guide that looks at the two major candidates' proposals. And one of the things that you'll find is that the biggest holes in both of their budget packages comes from that they both don't plan to pay for extending the tax cuts. They're pretty fiscally responsible on a lot of different efforts after this huge hole that they would dig, which is they would extend the tax cuts and fix the alternative minimum tax without paying for a dollar of it. Also, another point would be that their health care plans are some of the biggest ticket items that they do have in their budgetary plans. And I think on the issue of health care, we just need to go back to this basic premise. If it's something we want, it's something we have to pay for. Now, the underlying structure is critical. How we organize our health care system, who pays for it, how much people get, who makes the decisions, all of that matters. We have to synthesize what goes on in the private sector and the public sector. But bottom line, in the public sector, if we're going to spend more on health care, we have to pay for it. And that helps make the decision-making process more balanced. So sort of a simple question you ask, and I think it actually goes to the heart of getting back to kind of the values that will help fix this.
Well, we're just about out of time. I think we have time for one very quick question and maybe a quick answer. Yes, sir.
Vic Miller with Federal Funds Information for States, and I track the federal budget for states, so I know a little bit about both, and I know that state and local governments never collect more than 10% of GDP in taxes. You can go back historically, that's what they do, and we have Medicare and Medicaid, massive increases in percentage of GDP that they're going to spend, we're going to spend on Medicare and Medicaid, one word, I guess. Where are state governments going to come up with these revenues for Medicaid? We actually have a constraint on Medicaid. We don't have on Medicare, unless you think there's another way it's going to work.
Anybody want to tackle that one? Where's the money going to come from the states? Bob, that's your bailiwick.
Well, everything we've been talking about here about slowing the rate of growth of healthcare costs is critical for states, just like it is for the federal budget. So there's a huge amount at stake for states there, too. You know, otherwise, other things, education and other things, I think will get increasingly squeezed over time. And probably Medicaid will get increasingly cut back over time. I mean, a not very well-known fact, in the median state, the income limit for covering parents, working parents under Medicaid is only 63% of the poverty line. This is a reflection of the kinds of budgetary pressures Vic is talking about. I think there also is a very big need, hard to do at the state level, to deal with structural tax problems. Most state sales taxes are largely goods, while the economy increasingly has a larger share of GDP and services, so the sales tax base is eroding. States are losing corporate tax revenue as capital becomes more mobile and corporations find more ways to evade taxation. And a sleeper issue is that a number of states go well beyond the federal government in providing non-means tested tax breaks to people 65 and over, which states could afford more easily to do when the elderly were a smaller share of the population. But actually it is not a wise policy for states to continue to maintain that tax policy going forward, but it's going to be very politically difficult to reverse it. So we all talk about the long-term problems fiscally at the federal level, but as Vic is indicating, they're really bad at the state level, too.
And it's probably also worth noting that a lot of the Medicaid problem is a long-term care problem, not a medical care problem. Well, thank you all for coming. Thank you to Henry Aaron and Julie Barnes and Bob Greenstein and Alice Rivlin and Gene Sterling, and especially to Maya for hosting this. And thank you all for coming.